Assalamu alaikum wa rahmatullahi wa barakatuh, and good afternoon, everyone. I would like to start by thanking the organizing committee for asking me to talk with you today on this interesting model of how do we prevent fractures in osteoporosis. Prevention of fractures in osteoporosis is a relatively new concept that came around 12, 13 years ago, but people have been talking about it for a very long time because this is the main aim of dealing with osteoporosis. We want to stop the fracturing, which is the main complication of osteoporosis. But till recently, we didn't know the best tool to address that. So you probably will notice I'm just trying to figure out where is the, yeah. So you will notice that there are different terminologies. So you might come across something called CTF, capture the fracture, post-fracture care, or fracture liaison services. Professor Ahmed has addressed that part in his presentation, so I might skip over some of the slides. So the concept of fracture prevention or capturing the fracture came around 12, 13 years ago in 2012. It was a concept created by the IOF. I'm not sure if this is the, oh, I'm sorry. I'm trying to figure out if there is a pointer. No. Okay, right. So the model came in 2012 after years of data and publications addressing the problem of how do we identify patients who are at a risk of fracture. And it was, as classically always said, a teamwork. So it was a collaboration between the IOF, the International Osteoporosis Federation, and Oxford University, and two major pharma companies, Amgen and UCB. And the whole idea of that model is that we need to address those who are at a high risk of fracture. It's a multidisciplinary approach with multiple teams and a coordinator being the backbone of that team. So that was the model that they are trying to build. And by now, this is the most recent data. We have more than 900 FLSs all over the world in 56 countries. So it has expanded tremendously, particularly over the last 3-4 years post-COVID. So it started by a position statement that was launched by the IOF. Some of you might recognize the famous names up there, Keynes, Paul Mitchell, and Cyrus Cooper. And at that time, in 2011, they put that position statement that was published in the Osteoporosis International Journal, addressing what we already know, that fractures beget fractures. It's a domino effect. Once a patient has one fracture, they will at least double the chance of another fracture. And that's what we want to do. If we can't prevent the first one, at least we can do something about the second one. And that almost half of hip fractures will provide us with an opportunity for preventative action. And the model, as I mentioned to you, is a coordinator-based model with a multidisciplinary team approach to tackle the problem of interaction between the different groups. Now, as I mentioned to you, we had data, we had publications at least for 15, 20 years before that position statement talking about the same concept. So for example, the famous Harrington, a rheumatologist from the United States of America in 2006, used this beautiful metaphor. He said there is a Bermuda Triangle compromised of the orthopedic surgeons, the primary care physician, and the osteoporosis expert into which the fracture patient disappears. We lose patients because we do not talk among each other. So the patient gets lost in the journey. And that's what this model is trying to capture. We want to know where the patients are so we can deal with them early on. And this is, again, two famous publications, one of them by Keynes, addressing that 50% of hip fracture would have had at least one prior fracture that went unnoticed. So we are losing patients by not paying attention to the first fracture. And even the other statement, again emphasizing that by the time a patient has a hip fracture, that patient has been losing bone mass for the last 30 years. We are losing 30 years of a patient's journey by not addressing the first fracture, even if it's a minimal fracture. And this is a famous model that is used by public health experts comparing primary prevention to secondary prevention. So in osteoporosis, in the hip fracture area, if we want to address primary prevention and address 50% of the hip fracture, we will have to screen at least 84% of the population. And this is time-consuming and not cost-effective. While if we address the top 16% who will have 50% of the hip fracture, it will be more cost-effective and easier to address. And this is what we mean by the secondary fracture prevention, or the fracture liaison service, or the capture the fracture concept. So this is the main aim. We can address at least 50% of hip fracture by addressing those top high-risk patients. And these are the publications I've mentioned about. So in 2012, Ganda from Australia, he had this beautiful systematic review meta-analysis talking about the same thing. We've been talking about fractures for the last 20 years, but patients are still fracturing. And there is this care gap that we haven't closed yet, and it's time to do something about it. Ganda, in the same publication, he compared a few of the famous FLSs in the world. The famous one is Glasgow in the UK, but he compared multiple ones, and he showed that if we can create a simple, basic program, identifying those after a certain age, like 50, and with a fracture, with an osteoporosis fragility fracture, investigate them, rule out secondary causes, do a BMD and all the other tests needed that you have heard from the previous speakers, we can at least make sure that 50%, at least 80% of them will have a BMD, 50% of them will have a treatment, just by following this algorithm. And as I mentioned to you, this is a bit of an oldish slide in 2020, but you can see how many FLSs were sprouting all over the planet. In the MENA area, in that time, there were only 9. Now you'll be surprised that only in Saudi Arabia we have 11, and we would love to have more. But from 2019 till now, we managed to go from just 2 to 11. So we are doing a reasonable job, I think. And this was the campaign that was launched in 2012 by the IOF, Stop at 1. It's enough to have one fracture. Let's not wait for the second one. And they published what they call the best practice framework for fracture liaison services. It's a beautiful document, a bit lengthy, but it's beautiful. It explains why we need FLSs, how to form your own FLS, what are the forms you have to fill up, how do you apply to the IOF, and how do you get certified for having a fracture liaison service in your hospital. And again, they have a lot of educational material, webinars, a lot of educational tool addressing why we need a post-fracture care, how it is implemented, how does it benefit the patient. They address the care gap. And if you remember, Prof. Ahmed mentioned about the care gap all over the world. So it's not just in our area. This care gap of 80% of osteoporosis patients with fracture who are not addressed is still a serious problem all over the world. And I'm just going to share with you a few slides from Europe and the United States. So we know that the projected number of osteoporosis and osteoporosis-related fracture will be on the rise. And the cost of this disease, cost from morbidity, mortality, financial aspect will be horrendous. You probably remember Prof. Ahmed mentioned it in billions. We're talking about billions of dollars in all countries. And this is a very high cost for disease or for a complication that can be easily prevented because we have the tools to prevent that. So they capture the fracture. If you go to the website, you will realize that they are very active and they keep publishing new evidence and new scientific research. They have along with the best practice framework, they have educational material, they have slide kits you can use, other toolkits, webinar, global patient charter, mentorship programs. And you probably heard that some of us are certified by the IOF for mentorship program. And they have something interesting called the benefit calculator, which we still don't have it, but it's a calculator that based on the individuals or the specifics of every country. So they calculate for you how cost-effective it is to have an FLS. They calculate the cost of the disease, they calculate the cost of the complications, and the cost of implementing the FLS. And they showed it for many countries to be very cost-effective. We hope that we'll have that very soon. Just to emphasize that it's a teamwork, so it wasn't just the IOF alone. So they had multiple partners, and now they are building partnerships with multiple countries, including Saudi Arabia. You will notice in the MENA area, it's mainly Saudi Arabia there. So they are very interested in building partnership programs with us, and we've already started that, as I mentioned to you, and we have certified mentors. So this is a beautiful slide that just addresses, it doesn't matter which pathway you take. You want to take a bottom-top approach or a top-bottom approach, meaning do you want to have first your institutions providing the database and the tools for the fracture prevention programs and then go all the way to the policymakers and changing the national policy, or you can start from the top, convincing the policymakers and the regulators of the importance of your plan and go down the path. The most important thing, you want to create more FLSs, you want to capture more patients, and you want to address this problem of fragility fractures on the rise and the care gap in the management of the fractures related to osteoporosis. So this is the main goal. You want to create a policy change. You want to impress the regulators of the importance of what you are talking about, that preventing fractures is cost effective. It will reduce the cost to the country, the mortality, the morbidity, and the other aspects of the disease. As I mentioned, you will see a lot of publications on their website. All of them are very, very important, addressing how the vertebral fractures are as important as hip fracture. We all talk about hip fracture and forget that vertebral fractures do kill people as well. So we're not talking about just fractures creating disability. We are talking about mortality as well. And again, there is still a huge care gap there, and we need to do something about this post-fracture care, including looking after the patients where they live. And I think maybe Dr. Walid Al-Kredi will address how to prevent falls that lead to fractures in the geriatric population. So it's very important to address how we can prevent the fall, how we can ensure a safe home for the older population who are at a high risk of fracture. Prof. Ahmed mentioned the course of the disease. You can easily see the difference between osteoporosis, fragility fractures cost, and what we worry about and talk a lot about, like stroke and heart disease. This is really, it says it all. It's a very costly disease. Unfortunately, it's still underestimated, and we are not addressing it properly. And if we know how to address the economic cost of any disease, particularly osteoporosis, I think we will manage to reach a conclusion. Now, just a couple of slides on what the European Union did. So this is a bit of a busy slide, but what they did was, again, they wanted to emphasize the projected number of cases and the projected cost of the disease. And they managed to show that it's on the rise, it's a very costly disease, and there is a care gap, even in Europe. So multiple countries in Europe, they have this 70–80% care gap. So it's an international problem and not just us. We tried to do something similar in Saudi Arabia. Again, many of you are familiar with the publication. Prof. Ahmed alluded to that. So this is a group from the Eastern Province supported by Amgen, and they did something similar to the European economic cost. So they published this, The Burden of Osteoporosis in Saudi Arabia, a scorecard and economic model. It's a projected model, by the way. So they wanted to address the same aspects the European Union did. And again, they mentioned that it's on the rise. The Prof. Ahmed mentioned that in the hip fractures in Saudi Arabia, probably the mortality rate is higher than in international. We don't understand exactly why. They showed that there will be an increase in the number. It was published in 2019, I think, and they projected till 2023, and they have data till 2030. I mean, projected data till 2030. So again, the same thing was mentioned before. It's a costly disease. It's on the rise. It's costing billions of dollars, even in Saudi Arabia, and it's high time to do something about it. This is a very, very small study that was a collaboration with the clinical pharmacy department in the College of Pharmacy in King Saud University, headed by Dr. Bandar Al-Balkhi. And it's the same thing. The same numbers are showing. I think Dr. Ahmed, sorry for the small print over there, mentioned the comparison between osteoporosis as a disease costing, I think, around 900 or 1,000 US dollars, and with a fracture, it will be 10 times more, reaching 9,000 or 10,000. So a disease can cost 10 times its actual cost because of the complication that we are not capturing early. These are a couple of publications, one from Khalid University Hospital, one from the National Guard, again talking about the care gap. Prof. Yusuf Saleh is over here, and this is his publication. And we are all saying the same thing. The care gap is huge. A very small percentage of osteoporosis patients with fracture are identified, investigated, and treated. The Ministry of Health have done a great job from 2018 publishing guidelines. This is the famous one, the National Plan for Osteoporosis Prevention and Management in the Kingdom of Saudi Arabia. And you can see one of the arms they did address at that time, creating fracture liaison services. So we've been talking about this for a while. The COVID came and went, and we are still addressing the same problem. The guidelines, Prof. Yusuf Saleh talked about it. They addressed the importance of a fracture liaison service and why it is important. And as I mentioned to you, we were collaborating with the IOF. So there were webinars and mentorship programs, and we have multiple FLSs now. Unfortunately, more than half of them are still blue, which means it's a center in progress. So we are still working on that. We have 4 certified mentors. You can see Dr. Mohammed Al-Muhayya, Dr. Salwa Al-Aidarous, Dr. Mohammed Bakhsh from the Western Province, and myself. Now, the last 2 slides is this interesting publication. So the IOF approached the Saudi Osteoporosis Society a few months back, and they said that we want to work on a publication or a landscape project for Saudi Arabia addressing solutions for fracture prevention. So this was the press release. And more or less, we are addressing the same data I just mentioned to you. We are talking about, this was by Prof. Slimani and myself, and we mentioned that the country is facing a rapid increase in the older population. The number of fragility fracture estimated to have increased by 25% with the cost, the one that I mentioned to you. The document itself is called Solution for Fracture Prevention. It's around 14 pages, but it's very easy to read because most of it are graphs and numbers. And it's just a summary of every publication that addressed fragility fractures in Saudi Arabia. So I think this is my last slide, and I would like to end by thanking you for your attendance and any comments later on. Thank you very much.